So today I'm going to talk about the use of mechanical insufflation-exsufflation in children, and it's going to be targeted around common questions and answers that I'm regularly asked about. So one of the things that we tend to find is that the device is called a cough assist, and cough assist was firstly developed by the Emerson company. Emerson was then sold to Philips, but they kept the cough assist title and they developed the cough assist E70. It's important to remember since then, multiple other devices have come onto the market, and the term mechanical insufflation-exsufflation, which is pretty long-winded, but is the term that has been adopted. All of you, I'm sure, are totally familiar with the device, but a mechanical insufflation-exsufflation device, for those that aren't, provides a deep breath in to provide a good inspiratory lung volume, followed by a rapid switch to negative pressure, sucking the air out, which increases the expiratory airflow. These two components, the deep breath in and the rapid suck out, simulates the flow changes that occur naturally during a cough. And the devices can be used non-invasively and invasively, and by that I mean with an endotracheal tube or tracheostomy or via a face mask. So are there any guidelines for the use of mechanical insufflation-exsufflation in children? So if we look at the Canadian Thoracic Guidelines, they have recommendations for airway clearance in children using long-term mechanical ventilation at home. They highlight that airway clearance techniques should be taught to children and caregivers as a preventative strategy if there's an impaired cough. And in the absence of contraindications, that manual and/or mechanical lung volume recruitment should be introduced to children with an impaired cough when it is less than 270 litres per minute. Manual lung volume recruitment, for example, mechanical insufflation-exsufflation, should be considered in those that are weakest and with those of loss of bulbar function and those that cannot cooperate. And they've graded that high at 1C. They also suggest that it should be used, as highlighted here, in tracheostomy patients and can be considered as a way to prevent an intensive amount of deep suction. We have specific guidelines with regards to certain neuromuscular disorders, and if we take the more recent spinal muscular atrophy ones, again, we have this highlight that an ineffective cough peak flow of less than 270 litres per minute warrants physiotherapy assistance, cough assist, mechanical insufflation-exsufflation devices, and other techniques. And they define that airway clearance should also consider manual chest physiotherapy combined with mechanical insufflation-exsufflation, and it's the primary mode of airway clearance in all of those patients that are non-sitters, and by definition, a non-sitter is an SMA type 1 child. They also say that in those children that sit, so those type 2 patients with spinal muscular atrophy, that it may be that that is indicated in those that have recurrent chest infections and an ineffective cough. When we look at respiratory management for the patients with Duchenne muscular dystrophy, an assisted cough technique, again, when your forced vital capacity is less than 50% predicted and the peak cough flow is less than 270 litres per minute. And if that can't be measured, you could look at a maximum expiratory pressure of the mouth of less than 60 centimetres of water. So again, we have this number of 270 litres per minute for providing a form of airway clearance that could be assisted coughing and with regards to mechanical insufflation-exsufflation. A further consensus paper looked at treatment and follow-up of patients with Duchenne muscular dystrophy, and they show in the early non-ambulatory and the late stage ambulatory patients, again, what we're doing is that we're looking at providing regular physiotherapy reviews in order to predict whether these patients are going to need cough assistance. In a most recent publication looking at the respiratory management of patients with Duchenne muscular dystrophy from the UK, They highlight this very nice guideline on the right-hand side here for the care of patients, the respiratory management, so all of it with individuals with Duchenne muscular dystrophy. But they highlight here in the triggers box, which I've brought up and highlighted in big so that it can be read at a later date, that again, we have this peak cough flow of less than 270 litres per minute in an adult, or a decline in the recorded value of children's and adults should prompt a specialist referral and consideration of airway clearance. So it seems that this level of 270 litres per minute for a cough peak flow or peak cough flow highlights the need for airway clearance in the form of cough augmentation techniques. Now, physiotherapists should be regularly assessing cough. And what they should be doing is they should be asking the patient, can you clear effectively? Do you clear well when you're well? And can you clear when you're unwell? Because your respiratory muscle strength will drop when you're unwell, and that can take you down to a critical level where you can't clear your chest. You should be looking for a rise and fall of the chest when they take the deep breath in component. The glottis should close, and you should hear an expulsive when they start to cough. And if you don't hear that, you can ask them to say E, 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 and look at the bulbar function and the clarity of it. You can observe the contraction of the abdominal muscles and the effort produced, and you're looking at how audible it is. Do you think that they can clear? And again, as I've said, you can measure the strength of the expiratory flow with a paediatric peak flow meter attached to a mask. And what you tend to find in children, in those that have a severe chest infection versus those that have no chest infections, that their cough peak flow will be significantly lower. And in this study, albeit small, it was sitting around 116 litres per minute unwarranted mechanical insufflation-exsufflation. Now, it's really difficult in children because we can't take the adult values to say that these individuals need mechanical insufflation-exsufflation if they're under the age of 12. But we do have these cough peak flow reference values in children. And what we can do is look at those, and if they're less than 50% predicted, it's a high indicator that they're going to need mechanical insufflation-exsufflation. I've just put up here other cough peak flow values that you can always come back to as reference values for you to evaluate. And this is an example here of the centiles and the cough peak flow reference values. You can take a height centile or you can take a weight centile, it doesn't matter. Now, as part of the ENMC neuromuscular guidelines for airway clearance techniques in neuromuscular disease, we looked at all of the reported studies with different cough augmentation techniques. So glossopharyngeal breathing and manually assisted cough, insufflation alone, assisted insufflation with a manually assisted cough, mechanical insufflation-exsufflation, and mechanical insufflation-exsufflation with a manually assisted cough. And we put the forced vital capacity as a percent predicted, the forced vital capacity as an absolute value in litres, and the cough peak flow values. And so in children, often you will have a forced vital capacity as a percent predicted, and you can use that value to look at what technique is going to be the best for them. But the bottom line is, the weaker the patient, the more infections they have, mechanical insufflation-exsufflation would be the treatment of choice. So in children, are there any studies showing the physiological benefit of mechanical insufflation-exsufflation? Many years ago, we published our outcomes looking at cough peak flow compared to other airway clearance stroke cough augmentation techniques in adults and children with neuromuscular disease. And I've highlighted the paediatric results. And mechanical insufflation-exsufflation increased the cough peak flow the greatest. You can also see from the control versus the patient groups that we have a significant increase in our peak cough flow, which is B compared to the paediatric control. There have been studies that have been carried out, and recent meta-analysis looked at those that benefit from mechanical insufflation-exsufflation, and they took out patients with ALS or motor neurone disease because obviously they're adult patients. So when you have the groups that particularly may have included children, we can see that treatment in this neuromuscular group favours the introduction of mechanical insufflation-exsufflation with regards to cough peak flow. So it's not just our study that showed that. So we can say physiologically, MIE improves cough peak flow in children with neuromuscular diseases. Are there any other benefits? Well, when we look at our forced expiratory volume in 1 second and our forced vital capacity with air stacking, highlighted here in red, and mechanical insufflation-exsufflation, which I've just highlighted here, also in red, you can see that for forced vital capacity alone, and not FEV1, that there is a prolonged up to 2-hour improvement. And that is not seen for 2 hours with breath stacking. It's only seen for an hour. So in this group of patients, you see an improvement in lung volumes that is longer than air stacking, but is only for up to a 2-hour period. So physiologically, we see an improvement in our lung volumes with mechanical insufflation-exsufflation. There have also been studies looking at EIT in these patients. And EIT is a new kid on the block looking at whether we are seeing changes in lung volume and aeration. It consists of electrodes being placed across the chest, which you can see here shown in the chest X-ray, and then it gives us an idea of ventilation and which areas of the lungs are being ventilated. These are images of a patient who didn't receive ventilation with spinal muscular atrophy type 1. The top shows those that are prior to mechanical insufflation-exsufflation, and this is with mechanical insufflation-exsufflation on the bottom B. What you see in the top part is that the lungs are poorly and non-uniformly ventilated prior to the MIE treatment. The left lung receives more volume and the upper lobes fill more than the lower lobes. When we look at post-treatment, we can see that the ventilation distribution is more aerated and equal. What we also find from the 6 patients that are here, and I've underlined those patients number 4 and 6, which do not require any ventilatory support. Although they had lower lung volumes than those that were on ventilatory support, there is the greatest change in ventilation in those patients. So mechanical insufflation-exsufflation may improve ventilation and recruitment greater than those for those patients that are on ventilatory support. However, it's a very small study and I'm only talking about 2 patients here, but I think it's an interesting area. When we look at mechanical insufflation-exsufflation settings in children, what do we know? This is a study by Britt Hove who surveyed European centres for what pressures and times they use. And you can see that there is a cluster of settings around +40 and -40, and a cluster of times around 2 seconds insufflation and 2 seconds exsufflation. And what she found was that this was predominantly the process that was used in Southern Europe. For example, Italy, Spain and Portugal, and the other areas of Europe used more unilateral or personalised settings. She also showed that the pressure increases that we prescribe for our patients as they get older, and so do the times. In a bench study also by Britt Hove, she looked at what are the optimal settings that we should be using for patients with neuromuscular disorders. And what you can see here, she's got different colours. So we've got 0.5 in the orangey red colours, 1 in the blue colours, and purple is for those times that are longer. And you really need between 1 and 2 seconds here in the blue and the purple to get equilibrium between the device and the lungs in order to get the maximum changes in expiratory flow and inspiratory volume. You can also see that pressures of 20 or plus 20 to plus 30 show the greatest change in the peak expiratory flow when it's delivered in children, and that also that shows a significant increase in our inspiratory volume, and pressures above that tend to plateau out. You don't see a dramatic effect on the bench model after that. She also performed this table of all of the flows and the volumes that were generated and colour-coded the criteria of what provided optimum settings. And to fulfil an optimum setting, you needed an expiratory flow of greater than 80% of the maximum value and an inspiratory volume of 75 to 95% of the vital capacity. And again, longer insufflation times produced that. You can see here in the green. However, we need to be cautious that these high pressures potentially caused hyperinflation and were potentially harmful. And this is a really nice study that answers one of the questions that we often get asked, which is, do I need to maximally insufflate my patient in order to get the best peak cough flow? And although Britt's work in the lung model says that we don't need to do that, this is in humans. So it's not done with mechanical insufflation-exsufflation, but the deep breath in is provided either via a lung recruitment mover or an intermittent positive pressure breathing device. And what they looked at was the maximum insufflation capacity, so how much air with one technique and the other technique the patients needed, versus the optimal insufflation capacity. And the optimum insufflation capacity was what produced the greatest change in cough peak flow for that volume. And this is just an example of some of the patients, but you can see here they're increasing the pressure, and this black dot shows the optimum insufflation capacity, and that pressure is lower than the maximum insufflation capacity. And it's the same for this patient, but not this patient. So some patients it will vary. But nicely, it showed that we don't have to insufflate patients maximally to get the greatest change in cough peak flow. And we retrospectively reviewed our patients with regards to our settings. And like Britt's study, we confirmed that the insufflation pressure in our cohort of paediatric patients was around plus 25 to minus 30. And we always used unilateral pressures in our paediatric patients, our SMA and our Duchenne's, in order to get the greatest change in cough peak flow. Britt's been doing an amazing amount of work looking at the perceived impact and use of mechanical insufflation-exsufflation in a group of patients. Here we have a group of neuromuscular patients, but she's one of the first to report a large group of patients with central nervous system disorders. And what I wanted to highlight here was that the central nervous system disorders tended to have a slightly lower insufflation pressure compared to the neuromuscular patients. She also looked at, in over 70 patients, what pressures are optimal. And she defined patients or provided them with symmetrical pressures, which was a pressure of plus 50, minus 50, with slightly different times for ages. Asymmetrical pressures, which showed a pressure of plus 25 to minus 40 in those that were less than 6 years old, and a greater pressure of plus 30 and minus 40 in those that were over 6 years old, and a fully personalised approach. She showed that the greatest change in cough peak flow was with the symmetrical pressures, the high pressures in patients of +50 to -50. Now, the patients actually rated that on a comfort scale as less comfortable than asymmetrical pressures that were lower and an individualised approach, but all were deemed to be equally efficacious. So there are two ways that you can set up children with mechanical insufflation-exsufflation. One way, after you've reviewed the contraindications and familiarised them with the technique, is to start in a basic auto mode with symmetrical pressures, +20, -20, slowly increasing until you've optimally titrated to the patient. And that tends to be quite a useful approach in individuals that are less familiar with starting mechanical insufflation-exsufflation, or if that's the protocol of your centre, for example, like we saw in Spain, Italy and Portugal. And that has provided effective results in patients. An alternative based on Brit's research is looking at what the age of the patient is. So if they're an infant or a toddler, child or an adolescent. And what you want to do is you will look at, first of all, setting the time. So between 1 and 1.5 seconds for those younger, but for those that are older, 1.5 to 2 seconds, so that we are getting that equilibrium between the device that she showed on her bench test to the lungs of the patient. Setting the insufflation pressure at 15 centimetres of water and titrating up. And you're aiming in infants and toddlers between 20 and 30 centimetres of water, higher in children, and 30 to 40 in adolescents. You allow the patient to adjust and acclimatise to the insufflation pressure. And then you can set your exsufflation time for at least half a second and increase the comfort. And you will set your exsufflation pressure to be more negative than your positive pressure by 5 or 10 centimetres of water, constantly reassessing the patient and seeing what's appropriate for them. So you have option 1, or you have option 2, a more personalised approach in order to achieve effectiveness in patients with neuromuscular disorders. So let's take a look around adherence to mechanical insufflation-exsufflation, because it's not the same as adherence to non-invasive ventilation. We know that adherence to non-invasive ventilation in certain groups of patients, you need at least 4 hours for any physiological benefit, but that isn't the case with mechanical insufflation-exsufflation because you're just clearing your chest. So this survey looked at how often people use devices, and we can see that the frequency of the device varied drastically from daily to weekly, fortnightly, monthly, and rarely. We also found that that was the case in our study when we retrospectively reviewed our patients and how often they were using it. We had some patients, again, that would use it on a daily basis, to those that used it hardly ever at all. And one of the questions is that if you take it away from those that hardly use it, does it matter? And the answer is we don't know that. But if we stop any admissions, that's cost saving. We know that patients with tracheostomies tend to use the device on a daily basis compared to those that don't. And we also found out that our SMA type 1 patients were a particular cohort that used it on a daily basis. And that was because they had a secretion burden. So I think what you're going to find is that those that use it daily are those that have secretion problems, but others will use it basically in order to target the times that they have secretions. Now, providing an extra device, does that mean that we increase the burden of care or decrease the individual's quality of life that we've provided it to? This study looked at mechanical insufflation-exsufflation in children in neuromuscular disease. They had 31 parents and caregivers who returned their questionnaire, and the satisfaction was high. And they reported that there was a low burden of care. So that's good. When we look at this study that was more qualitative, We found that between physiotherapists, patients and parents, that there were different themes, and I've just put some of them up here. So theme 1 was the physical impact of neuromuscular disease and the perceived value of the MIE device, and that it was highlighted that it improved respiratory function. We do it, and the saturation's improved. We definitely move more gunk. It brings mucus up. It's easy to use, but it had been reported by the individual that it makes them tired. It's very tiring, and that you can find that it's avoided and minimised the time in hospital. The social impact, was seen as an enabler, and it was seen that they got less sick with it. The emotional impact, it keeps them out of hospital, it decreased the fear of chest infections, it provided peace of mind and reassurance. However, there were barriers. There was a child resistance. I don't like it. It feels weird when it sucks out, and we know that if you've tried it on yourself. There's also time constraints in looking after a child who is technology dependent. You have so many things to do, and we're, as therapists, asking them to do another one. So we need to target when and how it should be used without just adding it as a recipe. It recently also looked at the user perception of long-term MIE devices in children with neurodisability. And she had a response of 71% that were less than 18 years old, and that the health-related quality of life, which is here in her individuals, was lower than a reference value in 4 out of the 6 domains. But when she looked at the perceived benefit of mechanical insufflation-exsufflation, it was high, but highest amongst those that used it daily. Most were reluctant or unwilling to pause treatment, and some patients reported a decline in physician visits, antibiotic use, and hospital admissions. This is just a nice summary of all of the paediatric studies and what the benefits of them have been. And I'm just going to leave this slide in here for you to come back to should you want to look at this in more detail. When it comes down to acute care, what considerations do we need to take in mind? We know that in individuals with an artificial airway, albeit that an endotracheal tube versus a tracheostomy, that the pressures that are needed to deliver the same expiratory flows will need to be higher than that with a mask. And you can see this, the expiratory flows here between the endotracheal tube in black and the face mask in grey. So if a patient is intubated, you will need to increase the pressures probably on their device so that they're effective in the acute situation. We also looked at our patients that were going for pre-surgical procedures, and we felt it was important that we taught them appropriate airway clearance techniques, and if they weren't introduced to mechanical insufflation-exsufflation, they should, because as part of their extubation regime, that we would attach the equipment to the ET tube, perform regular airway clearance, and continue this after extubation and optimization when the saturation's dropped below 95%. So again, it's important to review people prior to surgery to ensure that they have the most appropriate techniques. In the acute setting, we found that the use of mechanical insufflation-exsufflation shortened treatment compared to conventional physiotherapy. Patients reported that there was a greater decline in secretions, but in that group, however, that they were more fatigued. And when we look at the effects of mechanical insufflation-exsufflation in children with neuromuscular disease, we can see that long-term use, in albeit a small study, has shown that there's been a reduction in hospital admissions and number of respiratory tract infections in that group after the provision of MIE, which is promising. And I know that Esther Velderholm is doing further studies looking at optimal timing for this device. What else can be done to help? Well, we know that some of the barriers to the provision of mechanical insufflation-exsufflation are education and confidence. And it's not always possible to bring people into the hospital or to have a face-to-face tutorial of the device. This group from Australia showed nicely that a intervention group, which received online modules and training with regards to mechanical insufflation-exsufflation, improved or reported an improvement in their confidence compared to a control group that received nothing, with confidence and competence in using the device. So we should think about this as an option if we are finding it difficult to train or familiarise people with it. We need to be looking at the changing evolution of our cohort of patients. The use of nusinersen and gene therapy is changing when patients with spinal muscular atrophy may need ventilatory support. And we also need to look at the changing evolution of the diseases that we're treating. This is an abstract report of individuals with spinal muscular atrophy that were treated with emerging therapies. And what they found was that despite the fact that these patients were doing better from an ambulatory perspective, that they were finding that they had chronic suppurative lung disease and bronchiectasis on CT scan. So if you're finding that patients are having excessive secretions that have been cleared but taking a prolonged period of time with mechanical insufflation-exsufflation, we should be looking for this, and perhaps they need to have an alternative secretion mobilizing technique instigated in order to ensure optimal chest clearance. Other things that we need to do is look more carefully at the efficacy of our treatment. We need to ensure that we're getting patient feedback, and that might be by sputum production. We can listen over the trachea with our stethoscopes to ensure that air is going in and coming out when we're performing the procedure. We can look at our cough peak flows, our inspiratory volumes and our expiratory volumes, and in some instances it's useful to look at the graphical analysis of the devices. Here we can see the inspiratory flow, and this is the start of exsufflation, and this is the true cough peak flow of the individual. This is one patient that I saw in clinic who liked to have an insufflation, followed by an exsufflation at this point. And you can see that there's a nice inspiratory flow with the inspiratory pressure, and we have some expiratory flow. I decided to change them to have insufflation-exsufflation, and we get the first good insufflation, but then we have upper airway closure. And so this technique, without looking and interpreting either via auscultation or having better feedback, I may have switched them to a treatment that was less effective. So I think we really do need to be paying a little bit more attention to evaluating the effect of treatment. So I'm going to stop there and just highlight that cough peak flow might not be the best measurement for the prescription of MIE in children, because it's around the value of 270 litres per minute to instigate and 160, which are adult values, and maybe looking at the forced vital capacity as a percent predicted would be a better option. There's no one way to start MIE in children. You can go for a personalised, asymmetric or symmetric method. You will get good results with each. It's just evaluating the treatment. Adherence isn't a standard time or daily use like ventilation, and we need to weigh up how many infections it may have prevented or hospitalizations, and further work is warranted in this area. Looking at mechanical insufflation-exsufflation in children, I would say it's really well tolerated and can improve quality of life and decrease respiratory tract infections. We need to ensure that it's introduced early and used in acute care to get the benefits of it, and that we may need to adjust and adopt our settings appropriately. And finally, if you have a patient who's using MIE effectively, but is having long clearance times, then perhaps we should be reviewing them for bronchiectasis due to either chronic aspiration or chronic suppurative lung disease. I'd like to thank you for your attention, and if there's any questions, please either email or X me. Thank you.